Okay, hi, today we're going to do our presentation on respiratory problems or issues of the respiratory system. I decided I'm going to try and make this a little bit short and sweet, but I think that there are some things that we need to discuss so that we'll be able to talk about upper respiratory disorders and lower respiratory disorders. So I think you need to have a good basis of what's going on with the respiratory system. So today we're going to talk about diagnostic testing, the assessment, and airway management. And so I'm hoping that in second video, I'll talk about upper and respiratory disorders, and then we'll talk about respiratory medications a little bit more. So let's just sit back and kind of ride. Some of this will be a little review for you, and some of this may be new material for you. So, like I said, we're going to discuss a little bit about the basic concepts. We're going to cover a little A and P here. And the first thing I want to kind of cover is I want you to have a little understanding about the upper respiratory tract, so that when one says there you have an upper respiratory tract infection, you'll have a clear understanding of what consists of the upper respiratory. So the nose is part of the upper respiratory, and its job is to humidify the air that's coming in, warm it up, make it moist, and to kind of filter out. You know, you have nose hair, so that helps out with the filtering of it. Your mouth also is part of it. You have sinuses. They're air-filled cavities, we'll call them, that also assist with speech. You have your larynx and pharynx, and your larynx is basically just a pathway, and we'll call it the quote-unquote the throat. And your larynx, which we have been told it's our voice box, it houses your true and false vocal cords, okay? And remember, they do the vibrating so that, you know, speech is heard. Also in a part of that is the epiglottis, and it's kind of a cartilage-like flap. And when it's at rest, it sits up and allows air to go into the lungs. And when you're actually swallowing, it folds backwards over so that it'll prevent any kind of food or fluid from going into the trachea. So that's kind of what's going on as far as upper respiratory is concerned. So now we have lower respiratory. Your lower respiratory is going to be your trachea, your main stem bronchi, your bronchioles, the alveolar ducts and alveoli, and your lungs, okay? So we know that the trachea, which everyone, you know, pretty much calls your windpipe, okay? It kind of sits in front of the esophagus and is further divided into your left and right main bronchus, okay? And it divides right at the, what we call the carina. The main stem bronchi starts at the carina, and it is, it has your right side, which is your right main bronchi. And what I want you to know about that is this one is slightly wider and shorter than the left, and it's also straighter. So one of the things that kind of that we should know about is because of the way it's anatomically formed, it has the tendency to get foreign objects trapped there. And when we are trying to intubate, sometimes we go over that way. And we'll talk a little bit more about that later. So then you have your bronchi, and then it breaks off into the bronchioles, which are smaller tubules. And then you have your alveolar ducts, and you have your alveoli, which are going to be the small clusters. They're at the most distal end. And the clusters of alveoli is actually where the gas exchange happens. I guess I can say that's where the magic happens. And so I think that that is very important for you to know, because the respiratory system's main job is gas exchange. So we really wouldn't want to be confused on what goes on there. Another thing I want you to know, when I say gas exchange, remember that's going to be a little bit of what we talked about in our fluid and electrolytes. And I'm not really sure if you guys got that video or not, so I'm going to try to re-get it out there for you. Gas exchange, that's kind of like what goes on with diffusion, and you have your carbon dioxide and your oxygen doing their exchange there. So you blow off the carbon dioxide and the oxygen goes into the blood to be circulated. The one thing I would like for you to also know about the alveoli, which are the clusters, and to be honest with you, there is a cluster of them right there on the screen in my picture, is that this is also where surfactant is produced. Okay, and surfactant is very important. Okay, so I want you to, if you can, write that down as surfactant. And its primary function, and I want you to hear me out, is to reduce the surface tension. And so that makes sure that we have more area to, and that is more area to do this gas exchange. So we have better gas exchange. So without the surfactant, we're not going to be able to do gas exchange as well. Okay? And they also keep the alveoli having good expansion and from collapsing or sticking to each other, okay? So it keeps them nice and kind of inflated a little bit. And I'm going to throw a side note in, and I'm sure I'm probably, I found my PEDS girlfriend, so she threw a PEDS lecture out there for us. So we're having a great time to help you guys out with LS1. And we're going to definitely try to move on to LS2 as well, and in addition to our primary roles. When a baby is premature and have not had the opportunity to produce this surfactant, they're going to have immature lungs, and they're going to have an issue, a lot of respiratory issues, okay? So that's my little side piece there for surfactant, just so that you know that. Now we got to talk about the lungs. And of course you know that the lungs are our main muscle there. And they start pretty much at the top where the clavicles are, and they go all the way down to your diaphragm. Okay? The right lung is larger than the left. It has 3 lobes. And when we talk about these lobes and we chart on these lobes, we call them the upper lobe, the middle lobe, and the lower lobe. And the left lung only has 2 lobes. And it's the reason why is because it needs to make room for the heart. In order for the lungs and the respiratory system to do their job, they're accomplished pretty much by the phrenic nerve, the vagus nerve, and the thoracic nerve. And I'm going to kind of hit back on the phrenic nerve in a little bit, okay? We're going to talk about accessory muscles of respiration. So this is also the muscles that are needed in addition to the lungs. And the first muscle I'm going to mention is the scalene one. And it is actually the lung, the muscle that is in the front of the neck, and it goes up the sides. You have the sternocleidomastoid, and it is in the front all the way down to the clavicles, and it goes all the way up to behind your ear. And that's the one that pops out when someone is angry. Okay. The next one I want to talk about is the trapeze, and it's in your back. It's the really good ones when you're working out. And then you have your pectoralis, and major and minor ones, and we know what our pecs are. And those are accessory muscles. And sometimes we get a little nervous when we see people working their accessory muscles. But I do want you to know that they are there. They help out with breathing, and that's their whole structure. Since we're talking about respiratory, I do want to hit on, I hope you guys know this, we have 12 pair of ribs. And then we have those muscles that's in between those ribs, and we call those intercostal muscles. So just in case I happen to mention the intercostal muscles, you'll know exactly what I'm talking about. And our diaphragm is separated by the thoracic cavity from the abdominal cavity. It's a very thin little piece of muscle, and it separates the thoracic from the abdominal cavity. And I think this is kind of important because occasionally we like to test this. But when the diaphragm contracts, it actually, or I'll say it contracts during inspiration, and then it actually relaxes during expiration. So if you actually take a deep breath in, you'll kind of know exactly what I'm talking about. We can't talk about the respiratory system if we do not address the issues that go on with the aging. As we age, different things happen in our body, and they're going to cause different signs and symptoms. And so I do want to kind of touch on that so that you have a basic understanding about our elderly population. Like I said, we're going to put out a PEDS lecture, and so we also want to talk a little bit about our elderly. I'm not going to tell you anything too new here, but as you get older, you have a decrease in your immune system, okay? And with that decrease, it's going to make you more susceptible for infections, okay? On top of the, and when I say infections, I'm talking about upper respiratory infections. On top of the fact that you don't even respond to those infections the same way you did when your body was a little bit younger. They have a decrease in cough reflex, okay? And so with that being said, we know that cough is the way that we protect our airway. And they have a decrease in this, so they're going to be more susceptible of having issues with aspiration. And that's important because you think about aspiration pneumonia and our airway in general. You also, around that time, we start getting lots of diagnosis of osteoporosis, okay? So this may end up with our patient having some kyphosis. And with that, that's going to inhibit full lung expansion. So not going to be able to have all this lung expansion. And we know in order to do this respiratory thing effectively, we need to have full lung expansion. Pretty much we end up losing a lot of elasticity and lung compliance. And that just means that the lungs are stiff. And that stiffness and that decrease in elasticity have effects on lungs, their function, and ventilation. Also, part of the aging process is the decrease in water overall, the decrease in water. Not only that, but the decrease in the intake of water as well. But the body composition, that water is what I'm referring to. And they both kind of play hand in hand. You have a 50% decrease in water after the age of 70. And how does that affect the respiratory system? It's going to make that mucus that they're having to cough up or whatever, it's going to make that thicker. It's going to make their mucous membranes stickier, okay? And so if we can't cough that mucus up and it sits there, we know that it's going to leave a good area for bacteria to grow, and we don't want that to be there. With that stiff lungs or the decrease in compliance, that's going to increase the work of breathing. So you'll hear me say that a lot, the work of breathing, because the harder your body has to work to breathe, the more likely the chances are that you will tire out and stop breathing. Okay. Just like with any other muscle, you start to have atrophy. Okay, and that's going to diminish the work of the muscle and the strength of the muscle. You also start to have a decrease in O2 saturations. I'm sure it has a lot to do with the fact of you not being able to have full lung expansion and being able to clear the airway and being able to have strong cough. And there starts to be a decrease in your response to hypoxia, and that's going to be a decrease in oxygenation at the tissues, okay? And your increase of holding on to carbon dioxide, CO2. So those are just some of the things that we notice with the aging population. And of course, you know, I'm not saying that everybody has these issues, but that puts our patients more at risk for doing that. I want to backtrack just a little bit because I want to put this in because this is important when we start talking about diagnostic testing. Remember our two lungs, got the left and the right lung. I told you about the lobes and stuff like that. Our lungs actually are covered with a transparent serous membrane. And so just so that it makes sense to everybody that is listening, and I'm not saying that, you know, we're not all on the same page, but we do have various levels of experience. That is a little sac. A little sac that covers individually each lung. And I had to bring that in because sometimes that little sac gets fluid in it. And when I mention it, and it's called the pleura, when I mention it, I want you to know what I'm talking about. Okay? We're going to move on. We're going to talk about the role of the respiratory system. And so one of the things I'm trying to do, and I do want to say that, is I'm trying to slow down. My last video was I was talking a little fast, and I did get some feedback on that. So I don't want to drag it, but I also want you to be able to take notes. I am going to send this PowerPoint along with some handouts, and if you have any questions, please feel free to email me or put it on our page or whatever. So the role of the respiratory system is to do our gas exchange, okay? So we're supposed to do the lungs, oxygenation, and tissue perfusion. And in order to do that, we need to intake oxygen into the lungs. And remember our little ball sacks of alveolar, that is where the gas exchange happens, okay? So now since we have the gas exchange happening, we're blowing off CO2, we're taking in O2, we need a delivery system. And the delivery system is my friend, yes, the heart, and it's pumping everything to the body, okay? And of course, in order for the delivery system to deliver its product, it needs a car, and the car is going to be red blood cells, aka our hemoglobin, okay? So the main thing is for us to provide oxygenation, to remove carbon dioxide and waste from the body, which is a product of metabolism, and then we have some secondary functions, which is speech, smell, and to help with maintaining acid-base balance. And we learned that from our last presentation. And for everybody that didn't get it, I promise I'm going to record it and get it out to you guys. Promise, promise, promise. How is the respirations controlled? So, the movement of the diaphragm and the accessory muscles and respirations are all controlled by the respiratory center in the brainstem, okay? I'm not going to read this slide to you. You may read it anytime you want and as many times as you want after the fact. But in layman's terms, I'm going to tell you what this is saying so that we're all on the same page. The respiratory center is controlled by the spinal cord and the phrenic nerves. The respiratory center is controlled by, they control the respirations by the spinal cord and the phrenic nerve. And that activity is regulated by chemoreceptors. We have chemoreceptors basically in the aortic aortic arch of the heart. But we also have them throughout our body peripherally. What happens is a normal person with healthy lungs, me, you, when we have an increase of carbon dioxide, which is CO2, those chemoreceptors tell the brainstem, hey buddy, you need to breathe in deeper and breathe faster to get rid of some of that CO2. Remember, our body's response to get rid of CO2 is to breathe faster. Okay? And just like with anything else, once the CO2 levels return back to normal, then we can return our respirations back to normal. Okay? Whereas, so I want to make sure that you get this, because this is the part that kind of is it. As our job, the primary role is when those chemical receptors sense that there's an increase in CO2, it makes us breathe. And depending on obviously how much carbon dioxide / CO2 there is, that's going to be how fast we breathe, okay? When the CO2 is blown off or at an adequate level, we will slow down. This next slide further explains, but I have something in red. I thought it was kind of important. There's somewhere about 19% of the population that are walking around here and they don't necessarily respond this way. This is not the compensation that their body has. So what happens with them is they have had CO2 levels that are elevated, that their bodies have gotten, I'm going to use the word immune to it, and it doesn't respond the exact same way. So in order for their respiratory center to kick in, they respond to decrease O2 levels. So when, and remember, every time I say this, I'm not talking about O2 saturations that we take by a pulse oximeter. I'm talking about PaO2, which is the partial arterial oxygenation, okay? And you can get that and only get that through your arterial blood gas. And we'll talk about those a little bit later as well. So this particular population, because they already have increased CO2 levels all the time, when their O2 level gets to a certain point and gets low, it says, hey, buddy, you need to breathe in more to get more oxygen. Okay? And that's the stimulus that causes them to breathe. So with that being said, if we try to make them have a lot of oxygen all the time, they never get the stimulus triggered. We call those patients COPDers, okay? And that's what that whole hypoxic drive thing is that we're always talking about, okay? I just wanted to explain it to you from that point of view. That's pretty much what we're talking about. As we go on, we're going to be talking about some respiratory problems. But today, like I said, we're going to basically cover the basics of it. And one thing I want you to know is when you have respiratory issues, there is going to be some kind of interference with gas exchange. Okay? When there is a respiratory problem, one of three things are happening. You're going to have something happen to the supply of oxygen, the readily available oxygen. There is something that is inhibiting absorption of oxygen, something that is inhibiting the gas exchange or the perfusion, and something that is inhibiting the transportation. The problems are going to be one of the three or a combination. You guys know the drill. Can't talk about the respiratory system without talking about risk factors. And I am sure that all of you guys know exactly what I mean when I say risk factors. A risk factor is going to be something that is going to make this person more susceptible to having particular issues, okay? So when we start talking about the risk factors, I'm going to start off with our mature patient. And our mature patient is going to be the patient older than 65. We're going to talk about smokers, people that have a history of smoking. I'm going to go on to talk about people residing in extended care facilities. Extended care facilities is pretty much what I put in this lecture, but I probably could have said crowded living conditions. The crowded living conditions could be the barracks, the dorms, a jail, a shelter. People who already have chronic respiratory issues, okay? Congenital or chronic cardiovascular disorders. Chronic renal disease. When you think about chronic renal disease, I started thinking about the fact that the kidneys is what produces erythropoietin. Erythropoietin goes out there and tells the bone marrow, I need more red blood cells. And remember, red blood cells is the transportation of our oxygen that we were talking about. Patients who have diabetes or other chronic metabolic disorders, and people who have a compromise or a decrease in their immune system. Wait, there's more. Allergies, chest injuries, exposure to chemicals, so occupational hazards, family history of infectious disease. If they have frequent history of respiratory illnesses, depending on where they live, geographic locations, or even if they have traveled to foreign places, okay? Remember that increased high levels, like above sea level, about 10,000 feet above, there is a reduce in O2 in the atmosphere. And that reduction in the O2 results in a lower O2 pressure and a lower PaO2. So when you think about geographic residence. Surgery, not only smoking, but chewing tobacco, viral syndromes, and the malnourished or poor nutrition patient. These are all of our patients that are going to be at risk for having, not that they're going to, but they're more susceptible for having respiratory issues. I'm not going to go over these terms, but you should know these terms so that when I mention them or when someone else mentions them, you were pretty much, I know you learned them at one point. We all have a medical background, but I want to also add to their hypercapnia and hypocapnia, HYPERCAPNIA, increase in CO2 level, and hypocapnia, HYPOCAPNIA, a decrease in carbon dioxide. So now, since we know who's at risk, the main focus of the respiratory system, how does it look? We need to know how these people come in. How do they present to us, okay, our patients? So here we are. We're going to get a patient history. And a part of getting a patient's history, we're going to talk to them about personal information. So how often do you get upper respiratory infection or, sinusitis, pharyngitis, that kind of stuff? What about your family? We'll go on to say, where do you work? Because we want to know if they are, do they work in asbestos, because they're a construction worker? Do they work at a chemical plant where they're, making plastics or whatever? We also want to ask them about their status of their immunization. So when did you get your last TB test? That's tuberculosis, pertussis, polio. Not that we really have to worry about polio. Did they get the pneumovax or flu shot this season? We want to go on to ask them about medications. And sometimes we forget medications are going to be over-the-counter, prescriptions, herbs, or vitamins, whatever it is, home remedies they're taking. So we want to make sure we cover stuff like that. We want to talk to them about smoking. And I got to have you a little side note about smoking because when we do talk about smoking, we need to talk about pack years. And a pack year is 20 cigarettes a day for a year. 20 cigarettes per day for a year. So that's a pack year. So the example that follows is going to be a person that smokes 10 cigarettes a day for 6 years. So you say, hi, do you smoke? Yes. How many cigarettes do you smoke a day? 10. How long have you been smoking 10 cigarettes a day? About 6 years. So they are 3 pack years. Remember, it is 20 cigarettes a day for 1 year. So remember, they're going to be half because they only smoke 10. Another example, 40 cigarettes a day for 20 years. So they're doubling. They're going to be 40 pack years. So remember that. And I'm telling you that because for some strange reason, we like to test that every now and then. Every now and then, an instructor or HESI or ATI or whatever test wants to put that, or boards on board. So I want you to know about that. Ask them about their drug use for obvious reasons. Ask them, are they allergic to anything? Not only allergic to medications, but you have to think about allergies and, hay fever or whatever the situation. Have they had any recent travel, especially outside of the country? Do not take for granted nutritional status just by looking at a person. You may want to get a better assessment of that. And then the patient that comes in, whatever their complaint is, you want to get a little bit more detail about the cough. Okay, how is this coughing keeping you up at night? Is this a dry cough? Is this a wet cough? Are you coughing up anything? And we call that sputum, right? So when you start thinking about this sputum, you need to talk about amount. How much are you coughing up? You need to think about the color. Is it clear? Is it tan? Is it green? So you need to think about stuff like that. And then you may actually want to go a little bit further and ask them about odor. Yeah, okay. And then consistency. Is it thick or is it thin? Is it mucoid or whatever? So you want to think about that kind of stuff when you're thinking about sputum production. You also want to start talking about chest pain. And not that I'm trying to jump the gun. I love my chest pain. But chest pain is also something that goes along with respiratory. And the first thing I want to know is, when I'm thinking about my chest pain, is, does it hurt when you cough, when you move, when you sneeze, when you take a deep breath in or out? If a patient answers yes to any of those questions, I think more respiratory, because cardiac chest pain is not related to any kind of movement. So remember, we talk about those intercostal muscles. If you have costochondritis, you will have some chest pain there, because that is like the inflammation of the intercostal muscles. Or if a patient has pleurisy, they may tell you it hurts right there. And if you tell a patient to take a deep breath in and they tell you, oh, that hurts, that could be pneumonia, or a PE. So that chest pain, that with all this movement and when it's exacerbated by something, is usually going to be a respiratory issues. Obviously, if I'm thinking cardiac, I start thinking about EKG changes and definitely, you know, troponins and so on and so forth. But chest pain is important in this as well. Dyspnea, difficulty breathing. When you think about this difficulty breathing, I think it's very important for you to note, is it at rest? So as I am sitting here in this chair, am I having a hard time breathing? Or does it just happen when I get up to walk? Or does it happen that I can't get out a complete sentence? So difficulty breathing. Sometimes as I am trying to put these lectures together really quick for you guys, I forget and put in acronyms and all kind of stuff like here. So here we go. PND is paroxysmal nocturnal dyspnea. And that's that sudden onset of difficulty breathing that happens at night and wakes you up. Paroxysmal nocturnal dyspnea. And that's PAROXYSMAL, nocturnal dyspnea. Wakes you up in the middle of the night having difficulty breathing. Okay? So that is some of the assessments that you're going to ask, and that's that conversation that you're going to have with your patient. Yay! Can't talk about assessment without doing a physical assessment. So a lot of you guys are probably looking like, Chica, I have not put my stethoscope in 12 different spots on a chest since health assessment in nursing school, and I do understand. But we should be doing our assessment as such as we are listening to lung sound. So I do want you to keep in mind that this is the correct way to do an assessment. And remember, as we are doing an assessment, we need to be always comparing the left to the right side so that we will know if something is diminished or something of that sort. Also, I want you to know that in order to do listen to lung sounds, you need to have your patient sitting up. Let's just keep that in mind. There's no way you can have full lung expansion if the patient is laying down. So it would be great if you can have the patient sit upright to listen to lung sounds. The first thing you want to know is that you normally start in the back, but not that it's going to be against the law to start in the front, but I'm going to teach you what boards may test. So you want to start in the back. You want to make sure to have your patient take a deep breath in, and we want to blow out of our mouth, okay? So in my practice, I say blow out the birthday candles, okay? Because then people know. I do want to forewarn you that anytime you tell a patient to take a couple of deep breaths, there's a cough coming, and they will cough in your face. So if you look at the diagram here, we're 1 and 2 here, and then you're always going to go from side to side because you're going to always compare your left to the right sides. These are lateral, guys, lateral. And then anterior here all the way down to here. And so you want to make sure that you are hearing a full respiratory cycle. And like I said, you have your patient sitting upright. And you are able to listen to what's going on. You want to start at the apex, which is at the clavicles, and go all the way down to the basis. And you want to make sure that whatever system you decide to use, that it is systematic, okay? And this is a system that you use all the time. Now, I'm sure by now you guys have kind of put it together that I like to have fun. I prefer to do all of this wonderfulness in front of people so that I can ask questions. But out of the love, I didn't get to necessarily do it. I do have some things I want you to listen to, though. Hold on. Wasn't quite ready, was I? That is pretty much one of the lung sounds I wanted you to hear. I'm not sure how well it came in. We'll try it again. Okay, so I wanted you to hear it a little bit. And of course, you're absolutely right. Those are crackles. That's exactly what it is. And I am hoping that with your wonderful assessment skills that you have, you are pretty familiar with crackles when you hear them. The next one I'll actually tell you. The first breath sound that you're going to hear is going to be your bronchial lung sounds. And for your bronchial lung sounds, you're going to basically hear those over the trachea. And you also can hear them over the sternal notch. And that's the sternal notch for all the people that are wonderful and following us with us. Okay, so this is going to be your bronchial, and your second one is going to be your vesicular. So if you notice, the vesicular was, the inspiration was longer, and then there was a gap. And it was louder than the bronchial ones, okay? The next one I'm going to have you listen to, I don't even have to tell you because we are all pretty good and we all do good with identifying this one. This is the one that we always get. Not so much yes, you're absolutely right. Good job, guys. That is going to be your wheezing. Not so much of all that whistling stuff that people say, but it was a little musical on the end. Try to get on YouTube, guys. Try to get used to listening to the lung sounds, because you're going to be the person, you sit your little cute self down in front of the board, you'll be like, I'm ready, and you're going to have a hot spot, you're going to push on something, you're going to hear something, and you're going to have to identify it. Last one. Right, you're saying, did she really make that one up? Yes, rhonchi. So I normally would say that rhonchi is kind of noisy. That's kind of how I describe rhonchi. Somebody else might describe it another way. I truly still believe that crackles sound like wetness and little bubbles or something. That's kind of how it sounds to me. I'm not really sure if someone else would say it sounds different to them. But that's pretty much what I get out of it. So I wanted to let you hear a couple of those lung sounds because how do you talk about respiratory system without? Let's move on. Let's talk about diagnostic tests and procedures. So pretty much you got a patient, you've gotten a history, you know gastric changes going on, you hear breath sounds, they told you what's going on with them and how many pack years they smoke. So now we're going to do some tests to try to rule out what is going on with this person. And the first thing we're going to do is we're going to draw some blood. First thing I want to talk about is the ABG, okay, arterial blood gas. This one's not a new one. Like I said, we did talk about this one before. Your ABG is going to be obtained from a arterial puncture, and it could pretty much be any artery. Normally, we get the radial artery, okay? It identifies oxygenation status, okay? It tells you about acid-base balance and compensatory mechanisms. I went over a whole lecture, so I won't really necessarily tell you how to interpret those. What you need to know afterward for the assessment or the nursing responsibility is that you need to make sure that your respiratory therapist or you, if you're drawing the ABG, apply pressure to the arterial puncture site. If the patient is on a blood thinner, you want to pretty much hold pressure longer. And so when I think about that, for your regular ABG, you want to hold pressure for about 5 minutes. And if they are on any kind of anticoagulant / blood thinner, you want to make sure that you give it about 10 minutes that you are holding pressure so that our patient won't bleed or anything. The second thing I would like for you to do is to make sure that we test what we call the Allen's test. And what the Allen's test does is to check for collateral, and that is ALLENS, collateral circulation. And what we do is we occlude, put our fingers over our ulnar artery and our radial artery, close our fist, occlude those arteries. If you open up your hand should be all white. If you lift your finger, and it's easier to do to someone else, if you take your finger off of the ulnar artery, it should make your hand turn pink because it should perfuse your hand. And we should be doing that before we do arterial blood gases in case we have a little flop or flip-flop or something and something happens to that radial artery, that person will still have perfusion to their hand, okay? The other blood test that I'd like to talk about is going to be the D, and that is the letter D dimer. And the D dimer actually assesses for thrombin and plasmin. And this is actually, no fasting is required. We don't need a consent or anything like that. But what it does is it will help us with diagnosing a pulmonary embolism or DIC, which is disseminated intravascular coagulation. So that is another test that we will take when we're thinking about blood tests, okay? So I definitely wanted to put that one out there. I next go on and I talk about sputum analysis, and I'm collecting the sputum for a patient. So when we get the sputum, we usually send this specimen down to microbiology, and they'll do like cultures and sensitivity or gram stain on it. And what we'll do is we'll have the patient cough. This is our job. We'll have the patient cough, or we'll do tracheal suctioning to get it. And the first thing we want to do is we want to have the patient rinse their mouth before collection. And like I told you earlier today, if you have your patient take a couple of deep breaths, they will cough. If I had to tell you something about testing, I need you to always, 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 always remember, yep, that means stop what you're doing and highlight or write, that we don't send things down for culture and sensitivity without, if they've already started antibiotics. So we always send down cultures, blood cultures, urine culture, sputum culture before antibiotics start. And for your sputum, you want to make sure that you transport it to the lab immediately. Okay. Other specimens we could do is a specimen for the acid fast bacilli, and that's the tuberculosis one. It has to be collected on 3 different days, and we usually want to do it first thing in the morning because you have your greater concentrations. So that's another one that we will do. And we also do skin testing. Don't want to stop it. I mean, don't want to forget about that. Detects allergies and hypersensitivities there. We'll also think about the TB testing for skin as well, the intradermal shot. As far as the TB testing, remember it is a intradermal spot. We put in, we'll usually make sure we put it on the forearm. And you should know this, guys, for measuring for your TB. You should definitely know this, that we need to read it between 48 and 72 hours after we give it. And a positive result indicates exposure to the antigen and not necessarily an active disease. In duration, not redness, but in duration is going to be the swelling of 5 millimeters or greater indicates recent exposure or possible HIV. And we confirm that always with the chest X-ray. In duration of 10 millimeters or greater, indicates typically active TB infection, okay? So definitely want to know that. And if they have a negative result, it means they have no exposure or anything. So that's for our skin testing. And we always want to make sure that we remember that. I want to move on to chest X-ray. Our chest X-ray basically is going to give us the anatomical locations and the appearance of the lungs. Our main job as the nurse is to make sure that the patient removes all their jewelry and that they have the ability to sit still for long enough and kind of hold their breath so that we can take this chest X-ray. We want to make sure that our patient is not pregnant if it is a woman. So we move on and we get a little bit more in detail with these, and we're laryngoscopy and bronchoscopy. So this is going to be your direct visualization of the larynx, trachea, bronchia, and with the fiber optic scope. Okay, so this is the little camera scope down your throat. And this is the important things I need you to know about this, and this is important, so write this down. You need a consent. We can't go down people's trachea without a consent. We actually need the patient to be NPO for at least 6 hours. We're going to get a baseline set of vital signs. We're going to check their coagulations. Make sure we remove their dentures before we send them down there and glasses. It would be nice to have suction prepared, emergency equipment prepared, and we would like to sedate them. It would be very nice not to put scopes down people's throat without having them prepared for that. After they come back from the procedure, we're going to do frequent vital signs for obvious reasons. Place them in semi-Fowler's position. They don't have to be in high Fowler's, but we need to have them able to protect their airway. Check for a gag reflex. Remember, we had them NPO, so we don't want them coming back and drinking or eating or anything like that without making sure that they can protect their airway. So we have to check a gag reflex. When they come back, we need to check the gag reflex because we don't want them to eat or drink anything without being able to protect their airway. One of the things I want you to remember is you're always, with the invasive procedure like that, is you're going to be monitoring for complications, okay? And remember, when you're taking boards, safety, safety, safety. So they're always going to tell you something about your patient is just returned from a procedure. Your patient is 2 hours post bronchoscopy. You need to know what those complications are and how they look. So they won't say, hey, your patient just came back from a bronchoscopy. Do you think there's a possibility they can have a pneumothorax? They're not going to say that. They're going to say your patient is 2 hours post bronchoscopy. He has a heart rate of 115. His blood pressure is 145 over whatever. He's complaining of difficulty breathing. You assess no lung sounds on the, whatever. Or maybe they even ask you what is the first thing the nurse should do, and you should be assessing lung sounds and checking pulse oximeter. So remember, before we start doing goofy stuff, we always have to do an assessment. So I'm trying to get you to remember, don't get so caught up. And I know what the complication is, know how it presents in our patients, okay? You want to make sure you're doing your frequent vital signs, and the chances of having these complications are going to happen somewhere within the first 24 and 48 hours, okay? And those complications are going to be bronchospasm, perforation, puncture of the lung, dysrhythmias, fever, bacteremia, hemorrhage, hypoxia, and pneumothorax. If the patient complains that they're having difficulty breathing or any of the other complications, immediately notify that dude, the doctor. The next thing I want to talk about is going to be your pulmonary angiography, okay? And this is another one that we like to test to make sure that you are able to educate your patients, because you're moving on your role. Your role now is as a registered nurse is a lot of education. And this is actually your invasive fluoroscopy procedure, in which a catheter is inserted into the femoral or the antecubital space, and we're putting dye in, okay? And what we're doing is we are trying to figure out if there are any blockages or anything like that. That's our main thing. We put a radioactive contrast medium in, and it identifies tumors or circulation abnormalities, okay? Our job is to assess for iodine, seafood allergies, shellfish allergies. That's our main thing. Our next thing is we need to make sure that we get a consent. Informed consent is what I'm talking about. And we need to educate our patients and tell them, you may feel some flushing. It may feel warm. You might feel some tingling. It might taste salty. You might get nauseous. Those are the things so we can prepare them, decrease some of the anxiety. Post-procedure. Post-procedure, we want to get frequent vital signs as well on this patient. Avoid blood pressures in the extremity that, we actually puncture for this for at least 24 hours. And we need to be doing neurovascular checks and assessing for bleeding. So everybody on the other end of this presentation is probably asking me, what is neurovascular checks? And neurovascular checks, I want you to immediately think about the 5 Ps. Pain, pallor, pulses, paralysis, paresthesia. Pain for obvious reasons. Pallor is color. Pulses is circulation. Paralysis is I'm not circulating, so I can't move. And paresthesia is that numbness and tingling. If by some chance you are ever having an issue with a fracture or thinking that it's a decrease in circulation, always think about your 5 Ps. The 5 Ps go with this because anytime we puncture an extremity or an artery, we can decrease circulation. The next thing we're going to talk about is going to be your thoracentesis. And everybody likes to talk about the thoracentesis. The thoracentesis is going to be where they put the needle into your thoracic cavity. We can do it for therapeutic reasons, meaning we can put in medications, or we can do it for diagnostic, where therapeutic could also be removing fluid that builds up in the pleural space, what I was talking about earlier. Or we want to test that fluid, okay? So we're removing fluid or air from the pleural space. And remember, this is going to be done under a strict aseptic technique. Not that you'll be doing it, but, so that you can tell Dr. Dan, hey, make sure you're good. It is usually done at the bedside, guys. So our lady who is sitting at the bedside right now, she is actually getting a thoracentesis. As you can see, she is sitting up at the side of the bed, leaning over on the bedside table. And we're going to tell her no breathing, no moving, no coughing, no sneezing. First thing I'm going to have her do is sign the informed consent. We're going to get vitals, and we're going to check coagulations. When I say coagulation, guys, I'm talking about PT-INR, PTT. I need to see, or ACT, to see the activated, the bleeding time there. Make sure you position the patient and tell them no movement during it. Post, you're always going to give frequent vital signs. Obviously, this patient is going to be at risk for a pneumothorax as well. You're sticking a needle just a little bit in, not so far to puncture the lung, but you possibly can. So vital signs, respiratory status, you're going to check for bleeding. You're going to check for crepitus, which is going to be little air pockets up under the skin. You're going to monitor for signs and symptoms of a pneumothorax, and obviously that's going to be your shortness of breath, decrease in lung sounds. You're going to check for air embolism or PE. In order to make sure that you're actually monitoring for signs of a pneumothorax, send that patient downstairs to get a chest x-ray if you can, and auscultate lung sounds, please and thank you. You want to make sure that you are charting the amount and appearance of the fluid that you get out, and the condition of the patient. Did they tolerate the procedure well, and so on and so forth. If the patient has an accumulation of fluid in the pleural space, and you removed 500 cc's out of the pleural space, they're going to have immediate relief. They're going to tell you they feel better, that they can breathe better. Because remember, if all that fluid is there, they're not going to be able to have that full lung expansion. So that's going to hinder their breathing. So they should immediately, start feeling better. So you want to make sure you remember that. The last thing I'm going to talk about is going to be as far as ventilation and perfusion. As far as diagnostic tests is the VQ scan. Ventilation and perfusion scan evaluates the blood flow through the lungs. Okay, the ventilation scan determines the patency of the pulmonary arteries and detects any abnormalities in ventilation. Once again, it's a radioactive isotope that's put into there. And like I said, it's also called the VQ scan. So lots of information, but those are normally, and there's other tests. You got pulmonary function tests also that could be in there. And we'll talk a little bit more about some of those things, but I just hit on the major ones. Pulse oximeter is a non-invasive one. The pulse oximeter is monitors for your O2 saturation. So the percentage of oxygen is bound to remember the transporter, the hemoglobin. And remember, this is always going to be in compared to how much hemoglobin is available. Normally, this number is about 95% or greater if there is no lung disease. So, not everybody gets to get 100% on this test. But remember, cold extremities will affect it. And so we got to keep that in mind. I think that's on another slide. I might have jumped ahead of myself. Capnography is a measurement of carbon dioxide. Okay. So here we go with treatment modalities. Okay. So treatment modalities. So we're going to talk about oxygen therapy, the incentive spirometer. We're going to talk about chest physiotherapy, and we're going to talk about nebulizers, okay? These are the things we do to make our patients feel better. I know you guys know everything about oxygen. I'm just going to do a small review because I like talking. How about that? So oxygen, as you know, it's a medication. You need to order for it. So let's not forget about that. Colorless, doesn't taste like anything, says some people. It is essential for life that there are some dangers. There is something called oxygen toxicity that happens. And I do need you guys to know that oxygen is very flammable. And what ends up happening is if we're sending our patient home on home O2, we need to make sure that we tell them there is no smoking and that they should probably hang signs around that said that a person is taking oxygen when they are there. Now, I do want to say I did try desperately hard to do this less than 2 hours. I think we're going to do okay, but I'm trying. Another thing I want you to know is that oxygen is also very drying to the mucous membrane. So if at all possible, we should try to humidify this so that they can feel better. When we are thinking about getting our patient on oxygen, we need to think about what equipment we'll need. And we'll need an oxygen tank. We'll need a flow meter, humidifier, tubing, and the appropriate mask appliance for the supplement of oxygen. Okay? So, room air. It says inspired air is 21% oxygen. So, room air, what we're breathing in right now is 21% oxygen. So, I'm not really sure how many of you guys might have known that, but it's one of those nice things to know. it does kind of help you out. Like I said, I am going to send you guys some handouts along with this. So just this is a FYI though. I have to be honest with you, but I am going to give it to you. Room air is 21% of oxygen. You add 1 liter of oxygen, they're getting about 24. 2 liters, 28%. 3 liters, 32%. 4 liters, they're right about 36%. 5 liters, 40%. 6 liters, about 44%. So that's kind of when you can kind of have a general idea of what's going on with your patient. Going up by 1 liter. 24%, 28%, 32%, 36%, 40%, and 44%. Okay. The purpose of giving oxygen is going to be to relieve hypoxemia. And I want you to know the difference, because I'm always trying to give you guys everything that's in my little head. The difference between hypoxemia and hypoxia. Hypoxemia is low levels of oxygen in the blood. Xemia, in the blood. And hypoxia is a decrease in oxygenation at the tissue level. You're like, really, girl? What? Huh? What she said? Yeah. So our goal is to always use the lowest amount of oxygen to achieve great perfusion and oxygenation without causing any harmful side effects of the oxygen. So like we're always trying to do the least invasive, we're going to give the lowest amount of oxygen, okay, to achieve our goal. There's the pulse ox. We pretty much have talked about it. All I really want to add about this is that we want to make sure that we don't have cold extremities. We don't have nail polish on. We can put it on different things. There are different ones, not just the one that go on a finger. We have ones that go across the forehead, ones we can put on the earlobe. Plenty of ways to get an oxygen saturation. It is a photoreaction of oxygen in the bloodstream. It's painless. And avoid direct sunlight, okay? Sometimes you do have to warm that little finger up because it doesn't always work so well. Yay! So, just in case everybody was wondering, I'm going to throw it out there. You know who did not plug up the camcorder thing right? This is where we cut off last time. Supplemental oxygen. So here I thought I would get a little goofy with you guys and talk about some of the oxygen apparatuses or appliances we use to give the oxygen, okay? So the first picture that we have here is going to be our flow meter, okay? So we can't give oxygen without a flow meter. This is the little dial. This goes into the wall. We put the bubbler or the Christmas tree up under here, and the little black ball goes up to the amount of liters. 15 is the highest. This is going to be your nasal cannula. Okay, these 2 prongs here go into the nose. Like I said, I do not know your background. This is a simple mask, okay? This is a, let me think which one it is. This is a partial non-rebreather. This is the regular non-rebreather. Yeah, it is a partial and a regular. Learn something new every day, don't you? And this is your venti mask with all the different concentrations here. So I had to put them all out there. I wanted you to be able to see them. I wish you could touch them and feel them. Let's talk about the nasal cannula. So when we're deciding to give our patient supplemental oxygen, the first thing we need to take into consideration is the patient's mobility, the importance of humidified oxygen, the comfort, and what is our goal? What are we trying to achieve by giving them the oxygen? How much oxygen do they actually need? Okay. Remember we said we wanted pulse oximeter readings, pulse oximeter saturations to be greater than 95. Sorry, that's 95. I'll take 92. Yes, I will. It's still an A on the test. And remember I talked about those other people that have decrease in oxygenation, our COPDers. I'll even take a 90 with them. So we need to take those kind of things into consideration when we're picking the appliance that we want to use. So the nasal cannula is picture number 2. They have the 2 nasal prongs. You can only give this patient about up to 6 liters, 1 to 6 liters. And with that, And with that, you get about 24 to 44% of oxygen. There's no benefits if it's greater than 6 liters. And I'll tell you why. Over 6 liters, we have this, what we call dead space in the back of your throat for real, and nothing goes on there. So we can use this long term. Patient can get up and walk around. I will humidify this greater than 2 liters. The third picture is your simple mask, and that's exactly what it is. It is a simple mask. Nothing great and special is going on with it. It's going to give you about 40 to 60%. It's for short term. Nobody wants that goofy stuff on them. You can use it up to about 5 liters. Okay. And it, it doesn't have the bag or anything like that. It's the nice one. It's no special thing there. It already permits humidification. And it's going to be the big daddy to the nasal cannula when you did not achieve what you needed to get with the nasal cannula. Or better yet, the patient's a mouth breather and the nasal cannula doesn't work, because remember, the nasal cannula has the nose prongs. Okay. We have the partial rebreather. Second picture, first line. You want to know the difference between the partial rebreather and the non-rebreather. The partial rebreather has only one of the, let me get up and show you what I'm talking about with my little red light. Hold on. So let me see how good I am. My producer is actually off for the night, or actually at work for the night, and I am actually recording alone. So I'm hoping that this works out for all of us. And as you can see, anyway, there are flaps here on the side. The non-rebreather has 2. The partial rebreather only has 1. And if you can see the white little flap here on this side. Okay, so that is the difference between the partial and the non-rebreather. Okay, partial rebreather gives you about 70 to 90%, 6 to 15 liters. The patient only rebreathes about 1/3 of the exhaled tidal volume. The thing that I want you to remember as a nurse is don't let that bag deflate. Do not allow any kinks or twists in the tubing. Non-rebreather, same thing. I'm going to say this. Non-rebreather is the big cousin. When you walk in your patient's room and the patient is on a non-rebreather, you like, dang, really? That's what's going on? Right, because you already know it's like that. So your non-rebreather provides the highest concentration. It can deliver up to 90%. Used when stuff is basically about to go down. It has a one-way valve and a reservoir and 2 flaps. Remember, over the exhalation ports. So your non-rebreather is actually going to keep you from rebreathing exhaled air. Okay, so you blow it out. You don't need to blow it back in. That's the whole purpose behind it. You need to keep the bag inflated. If it's not inflated, it doesn't work out for them. I usually put my patient on 15 liters at that point. And like I said, that's pretty much, some stuff is like that. You already know it. Now, if we move on and to our last picture with the little colors, the orange, the pink, the green, the white, and the yellow, that is a Venturi mask. And we will call that the Venti mask or the Venturi mask. And although it's at the last one, it's not balls to the wall. I have to be honest with you. It's not. It is more so, it provides a high flow of oxygen. It has adapters. The adapters are the little colors I just named off. And it actually allows the provider, to pick which one for the desired amount. So let's say the yellow gives you 30%, the white gives you 40%, the green gives you 45%, the orange gives you 65%. You can actually precisely put in how much oxygen you want the patient to have. And that's the advantage of the Venturi mask, okay? You can determine a predetermined amount of what you're going to go. It is somewhere about up to about 60% of FiO2 and about 4 to 10 liters that you can go on. So those are, oh my God, guys, there's a face tint, there's a trach collar, there's There's all kind of stuff. I can only put so many things up here, and I put the main ones that we were going to hit. And so let's go on. So there are some other ways that we can manage our airway. And when you think about airway management, we're always thinking about we don't want our patients to have any obstructions. So occasionally we'll have to put in an artificial airway. So also when thinking about an artificial airway, sometimes before we get, and I'll say before we get all grown and stuff, and we start throwing in artificial airways, we may just want to open up an airway by doing the head tilt chin lift, okay? And so what ends up happening there with the head tilt chin lift is this is when you're at Olive Garden and everybody got the never-ending pasta bowl, and people are eating and slurping, and you know it's bread up for everybody, and there's an issue going on, and something that went back down in the back, and of course everything in you says I'm a nurse, and so that's when you want to do your head tilt chin lift. If they're choking, obviously you do your abdominal thrust or your Heimlich maneuver or whatever. But I'm just saying in a regular situation, when you want to open up an airway, that's how you're going to open up your airway. But if by some chance you don't know what went down and you suspect that there may be some kind of neck injury or spinal cord injury, that's when we don't do the head tilt chin lift, and we do this thing called the jaw thrust. And that is important to know, and that's why I threw that in there, okay? So, and I'm sure you guys knew it, but I have to throw that stuff in there. Anyway, at the top is your endotracheal tube. When we say that we have intubated our patient, we're going to use the endotracheal tube. Second two in the middle are going to be your nasopharyngeal ones. Yep, your patient does not want the nasopharyngeal. Take my word for it. So these two, you're going to lube them up and stick them down the nose. This is your endotracheal tube in the trachea. There's a balloon there that keeps it in place. We put the air in the balloon there. That's the part we attach to the, I'm going to bag the patient. And then these are your just regular oral airways. Surprisingly enough, we stick these in upside down, tear the roof of their mouth up, and then we flip them, and then they end up in this position with the tongue up under and making the tongue lay out of the airway. You know the drill. That is pretty much what is obstructing the airway, is usually the tongue. So when we talk about airway management, that's pretty much what we're talking about. Endotracheal tubes can cause damage to the mucosa, so we don't want to keep them for a long time. They're short-term use, 5 to 7 days, and then we have to check cuff pressures, and that was that little balloon I was talking about. So you want to think about that when you're thinking about your endotracheal tube. I do want to say this, and maybe this is some added information. Everybody that has an endotracheal tube that is connected to a ventilator is not a patient that cannot breathe on their own. Like I said earlier, if by some chance you are working really hard to breathe, and we like, look, you're using all of your accessory muscles. Not only is your sternocleidomastoid popping out, I see nasal flaring, I see belly breathing, and all this goofiness. Then we may say, well, I'd rather just give your lungs a break and we'll breathe for you than for you to tire out and be like, I'm cool, deuces. So we don't want that to be the case either. So when we think about a little bit of long-term airway management, we start to think about the tracheotomy. So, and this is going to be a little bit more long-term. Okay. One thing I do want to say to you is tracheotomy is a surgical incision in the trachea, so we can maintain airway, and a tracheostomy is actually the opening. Tracheotomy is the actual incision, and tracheostomy is the opening. Okay. And so, what kind of nurse would I be without actually putting a picture of a trachea up there and how the doc does it? So if we take a look for a second, guys, there is where our opening is going to be there. And then this is our set here. So we have this is the outer cannula, this is the inner cannula, and this is the obturator. And this, now follow me, this obturator goes inside of here. That little slick ballish part will be out here. This flat part will be here, and that's how we put the the trach in, and then this is the inner cannula. Once we have this in place, and we don't do it, doctors do it, guys, you know the drill. Once we have this in place, we can put the inner cannula in. This is what we take in and throw away, or we take in and take out and wash and stuff like that. Hopefully we're not washing inner cannulas anymore. God, please don't let anybody work at a facility where we're washing those. When the patient gets the tracheotomy, it may be permanent or it may be temporary, just depending on what's going on with the patient. You know I had to do it. You know, I just couldn't be me if I didn't. Wanted to give you a little bit more information about the trach. Like I said, we have disposable ones, reusable ones. We have a cuff or one without a cuff. So let me show you exactly what I mean when I say cuff. I'm not sure how well your pictures are, but this is the cuff, the little balloon here. Cuff, cuff. When you hear fenestrated, these are little holes right here. Okay. That's your obturator again. Obturator. Remember, it goes inside of the outer cannula there. This can cause a lot of pressure. We put the air, and this is kind of like a little soft thing. We put the air in that way, and that's how the cuff inflates. Inner cannula, disposable one. Obviously, you can pinch these two things together, slide it out, throw it away, slide the new one in, everybody's happy. Same thing here. You can pinch them here. Okay, there are different types of trach. You have mostly what I'm seeing in practice a lot is the Shiley. I love the Shiley. It comes with the disposable inner cannula, and I take it out and squeeze. I hyperventilate, take it out, throw it away, slide the other one in. It's very simple. You also have the Portex one, and you also have the I've seen Bavonas. So those are the three I'm seeing in practice a lot. I'm in the Midwest, so I'm not sure if we're using other things. Let's talk about some of this stuff. The cuff, which is the balloon, once it is inflated, it keeps it in place. It's a seal. You know the drill. And anytime we have a balloon, whether it's a Foley balloon, an endotracheal balloon, or the cuff balloon on a trach, it can apply pressure, too much pressure on the area that it's in. So then we have the trach port, and that's where I showed you where we put the air in. You may hear some people say something about the neck, and I want you to know what the neck is. The neck is this. This is the neck. We have holes right here on the side. There are some holes there on the side here. You know, I'm always playing with this little red light. This holds your trach ties. Those little holes there. It'll tell you this is a size 6, it's a Bavonis or whatever. So the manufacturing information, the size of the trach and all that. They're calling it the face plate. People call it the neck. But yeah, that's what that is. That obturator should stay at the bedside in case the trach comes out, and you could put the trach back in with the obturator. Normally, if we have a patient with a trach, and I can say this in my practice, we will have that taped to over the bed, kind of like the sign that says don't use the left arm. We'll have it taped right there. The inner cannula, I pointed that out to you. It fits inside the outer cannula, and we use it, either we're going to take it out, clean it with water and peroxide. Oh, God, please. Or we're going to take it out, throw it away, and get a new one. And the obturator, like I said, it is a guide used to insert the trach. You're always thinking about safety, so I'm going to have to talk about a little complications when a patient has a trach in. And the complications are always going to be that there's too much pressure in the cuff that can cause mucosal ischemia. You want to check the cuff pressure. You want to prevent dislodging the tube, obviously. You want to make sure your patient is hyperventilated and make sure that they're not malnourished or anything like that. There's lots of different things we could talk about with the trach. Those are the main things that we're talking about, how stable they are, always checking hemodynamics. And when I say that, at this level, we're going to say hemodynamics are our vital signs. Suctioning. I wanted to talk about suctioning because for some strange reason, that's kind of what we've been talking about. You may see different things in print. The latest, greatest that I have found as far as suctioning is concerned is what I've put out here today. If by some chance you see something and you're like, I'm not going for that, what she just said, please feel free to reach out to me and say, hey, I didn't see what you saw, and we can go on. Obviously, when you're going to section a patient, and I'm not talking about with the Yankar suction, I'm talking about if we're going down for deep tracheal suctioning, we want to make sure if we don't have the inline that we have our patient sitting up in high Fowler's position. And I don't want to do fundamentally stuff with you, but obviously you're going to go in, you're going to grab your equipment, you're going to go in, you're going to introduce yourself to your patient, you're going to explain the procedure to the patient, and you're going to wash your hands. Right. You're going to do 2 patient identifiers. You're going to set up your station, put your patient in high Fowler's position. You're going to hyper-oxygenate your patient, whether that means you're going to turn the oxygen up a little bit or bag them 3 or 4 breaths, but you're going to give them extra oxygen. You are going to insert the catheter without putting your thumb on the hole to apply suction, but insert the catheter until you meet resistance and come out about 1 centimeter after that. As you are coming out, you're going to apply intermittent suctioning while twirling it or twisting it, whatever word you want to use, so it goes around and around as you are coming out. And so apply pressure while you're coming out, okay? Do me a favor, don't stay down there longer than 10 seconds. So this is where I said I was seeing a little bit different. And in the program that I work at, we are very strong on ATI. And so I'm using my Potter and Perry, and so lots of different things out there. I have always said 10 seconds. I saw some things say 10 to 15 seconds. I do want you to know this. I put 10 seconds out there because I found more that said no more than 10 seconds. If your patient becomes unstable in 8 seconds, can you come out before then? 5 seconds, they turn blue, just stop. Okay. After they are finished, I'd like you to hyper-oxygenate them again. Don't go down there more than 3 times, because remember, that's going to be trauma to the trachea every time you go down there. Don't turn the wall suction up higher than the 80 to 100. One of the things I want to tell you, I can tell you the procedures, I can tell you the steps in suctioning, but I am hoping that you understand there is no need to do an intervention, suctioning, if we're not going to do an assessment. So the first thing I would like you to do is to listen to lung sounds. Have your patient do some coughing and deep breathing. Check your respirations, check your O2 saturations. And then I would like for you to suction your patient. After you are suctioning your patient, that means you have now done an intervention, and now I would need you to reevaluate your intervention. I would like you to listen to lung sounds. I would like you to get an O2 sat again. And please do not call these O2 stats. They are O2 sats, as in saturations. So, complications. The patient could become hypoxic. You could have mucosal trauma, infection because you didn't use sterile technique going down there. You could have a vagal reaction, bronchospasms, cardiac dysrhythmias. Cardiac dysrhythmias is the one we really like to throw out there. Anytime you feel like your patient is not able to tolerate this procedure, you abort. If you go down there once and you feel okay with it, that's fine. Do not go down more than 3 times. That is very traumatic to go down someone's airway. Okay. All right, here we go. Balls to the walls. I always save the best for last. Mechanical ventilation. So, mechanical ventilation, let's talk about some reasons why we would intubate a patient. So, some of the indications is that our patient is having increased work of breathing. So, they're having a hard time maintaining their own airway. They're having NQ. They have gone into acute respiratory failure. And, oops, sorry, dropped that, didn't I? And there are some clear-cut definitions of what acute respiratory failure is. So, some of the indications that I want you to pay attention to, the criteria, is going to be a CO2, that's carbon dioxide greater than 50. Yeah, that don't sound good, right? Obviously, we're going to put their patient on a ventilator and make their respirations high. Exactly. Then we have a PaO2 less than 50. That sounds good too. And then acute issues with the pH. a pH less than 7.34, and a pH greater than 7.45. Those are reasons why we would intubate our patients. So I want you to think about those kind of things. Nursing responsibilities. Nursing responsibilities when I have intubated my patients to make sure that I have a working IV, I have sedation on board, and I monitor my patient, okay? Emergency equipment are always going to be next to the bed. The patient needs to be in a supine position, that is laying on their back, and they need to be, we're getting ready to intubate the patient, okay? And they need to be, their neck should be hyperextended, and we call that the sniff position. Nose up in the air. You know, some of y'all know about that. Anytime we're going down the airway, it is always a good idea to hyperoxygenate, put more oxygen on board because we're getting ready to mess with it. And we should hyperoxygenate after every attempt. And I don't know about Dr. Dan or what his skills are or anything like that, but we would like him to do that within 30 seconds and stop playing with our patient like that. After Dr. Dan has gotten the ET tube in place, our job, again, is always assessing. That is what we do 24 hours a day, 7 days a week. We are going to listen to lung sounds bilaterally and watch for chest movement. Okay. Sometimes we will hear no chest movement on one of the sides. Remember earlier in the presentation I was telling you about the right main stem, which somehow is shorter, wider, and straighter, and the ET tube will like to slide over that way. So we want to make sure that we're not there. Beware of, and we can just pull up a little bit. Oh, beware of the esophageal intubation, but you'll know about that. You'll be putting air into the patient's belly, and you can actually see their belly rising, or sometimes they'll just go ahead and throw up on you. And that is going to look like decreased lung sounds, absent lung sounds, or whatever. Another way we have decided to assess for proper placement is to do what we call a Untitled CO2, or obviously your x-ray. And remember, if we look at an x-ray, the tip of the ET tube should be about 3 to 4 inches above the carina. So for the level of this class, I want you to know that if a doctor intubates a patient at the bedside, my job is to make sure I have an IV that is working. I have a pulse oximeter on my patient's finger. My patient is sedated. He's in the correct position. I've hyperoxygenated him. I made sure that it is done between every attempt. And when that tube is in place, I auscultate bilateral lung sounds. If we think that it is in the right place because we hear lung sounds, we need to confirm it with a chest x-ray. That is my job as the nurse. I also will get through and I'll tape and secure the ET tube in place, marking where it is located at the lip line or the teeth line, just depending on where you work at. My next job is to pay attention to complications because safety is my other job. So I want to make sure we have no oral trauma, there's no trauma to the pharyngeal space or any hypopharyngeal trauma, vomiting or aspiration, or the obvious, my patient doesn't go into cardiac arrest. As far as looking at the ventilator, when they start talking about the ventilator, I need you guys to know that there's two types. We're going to have your positive pressure and your negative pressure. Your positive pressure is going to push air into the lungs, so the endothoracic pressure is increased. Okay? I need you to know about the vent settings and what goes on with the vent settings. So here are our vent settings. Rate, total volume, FiO2, and PEEP. This is basic knowledge, so you probably do need to know this. The rate is how fast we want the patient to breathe. So remember I was telling you, if by some chance the patient came in and was diagnosed with acute respiratory failure with a CO2 of 55, I taught you in the last class that CO2 levels are supposed to be 35 to 45. So now we have a CO2, carbon dioxide, of 55. What do we do to get that carbon dioxide level decreased? You're absolutely right. I want the rate up higher. So instead of the rate being 12 to 16, maybe I'll put the rate at 20 to 22. And we don't set rates. The pulmonologist does, or a respiratory therapist does, but you should be anticipating what's going on. So when somebody does something wrong, you could be like, hey, I was thinking that maybe we would want to, with the CO2 being 70, we would probably want him to breathe a little faster to blow off that CO2. So we do need to know that. Tidal volume, okay? With tidal volume, that is the total amount of air that a patient breathes in through their lungs, into their lungs. That's the amount of air, the whole thing that you breathe in. Well, so that's important to know. You also want to know what FiO2 is, okay? And that is your fraction of inspired oxygenation, okay, of O2 rather. And so you want to make sure that you know what that is. That is usually expressed as 40%, 30%, 20%, or whatever. Whenever there is a possibility that your patient comes in and they tell you that the FiO2 is 60, 70, 80%, you might want to start thinking about what's going on with your patient. Because those are larger amounts. But we definitely will talk about a little bit more about FiO2 as we get into disease process and acute respiratory distress syndrome. So don't think that I'm going to just skim over it. We'll talk a lot more about FiO2 then. PEEP. So let's talk about PEEP. Everybody wants to talk about PEEP. PEEP is pretty cool. PEEP is the amount of pressure. It is the positive end expiratory pressure. Okay? And one of the things I think you need to know about PEEP is it kind of goes hand in hand with your that surfactant thing I was talking about earlier today. So what ends up happening with the PEEP is that it keeps the alveoli open during exhalation so that we can, right, you got it, you're right, increase gas exchange. Remember, that's the main purpose. That's what we started this lecture talking about. That's where we're going to end it is. And it is expressed in terms of centimeters. So usually it's going to be anywhere between 3 to 10 to 15. The higher the PEEP, the more you need to be like, what's going on? So if I come in and my patient has a PEEP of 15, I'm like, uh-oh. If I come in, my patient got a PEEP of 3, I'm like, okay, 5 is pretty average. The higher the PEEP, the more there's an issue on why I am trying to keep this balloon open at the end. So that is it. So I want you to know it is the positive end expiratory pressure, PEEP, positive end expiratory pressure, and it is the amount of pressure at the end of exhalation, basically. So at the end, we still keep the alveoli open so that we can have this gas exchange, okay? I'm going to throw out some stuff. The higher the number of the PEEP, the lower your blood pressure is going to be. It increases the pressure in your chest, so keep that all in mind. And then complications of the ventilator. Let's talk about the ventilator alarms because this is what we test at the ADN, BSN level, at the RN level. You definitely need to know. Your ventilator alarm is going to either ring a high or a low alarm. If it is a high pressure alarm, that is something that means the pressure within the system. And when I say the pressure within the system being the lungs and the ventilator. So anywhere along that line, there is high pressure. Something is causing it to be high. And usually that is going to be the patient is coughing, the tubing is kinked, there's a clot or some occlusion or something like that. And usually we have to suction that patient or whatever. Low pressure alarms mean that there is a low pressure in the system. And that system being from the patient, the lungs, all the way to the ventilator. And we need to find out why. Why is it a leak? Why is there a low pressure in the system? So we need to assess the system to completely. The lungs to the ventilator to the lungs. And we're looking for loose connections or a leak in the system. If by some chance you have checked all of this stuff, you've suctioned, you've turned, you've manipulated, we've checked for connections and leaks and all this stuff like that, and the alarm keep going off, what should you do? I have a smart little group here tonight. You're absolutely right. Disconnect the patient from the ventilator and bag your patient. I know, 1,000, 2, 1,000. And then another complication would be accidentally decannulating your patient. Okay, I know y'all tired of hearing my voice. Almost over with, guys. So let's think about nursing goals. Now, don't think that we won't talk about the ventilator again. We can't talk about issues without doing it. But I don't have to go into the settings because you know what the rate is. The rate is how many breaths we're doing a minute. Tidal volume is how much volume we're breathing into our lungs. We talked about the fraction of inspired O2. So that's amount of oxygen that we're taking in via the ventilator. And like I said, it's in 0.40, that's 40%. And then we also talked about the PEEP, which is positive in expiratory pressure, the amount of pressure that's still left in the alveolar after. I don't have to go into that anymore. When I do my next video and I'm talking about ARDS, I can just say that the FiO2 is 70, and I know that that's the percent of oxygen. And I can talk about the tidal volume is 500, and you will know what I'm talking about. So that's why I kind of wanted to hit the basics, because I didn't want the video to be 4 hours long. Okay, anyway, so my nursing goals is going to be to promote oxygenation to prevent infection. Of course, we know this. One of the things that we nurses fail to stay on top of is washing our hands, washing our hands, washing our hands, washing our hands. And it makes me want to just go to wash my hands right now. If a patient already has issues, you want to tell them to stay out of large crowds, and especially during the cold and the flu season. And we always want to talk to our patients about smoking cessation and give them the information, and one day they will be ready to stop smoking. And avoid allergens if at all possible, and maintain adequate nutrition. We need to get some sleep. We need to stop moving so fast. And that goes on to talk as far as preventing further lung injury and promoting rehabilitation. Yep, she did it. Yep, that was me. I did it. Let's do it. The nurse is caring for several patients who are scheduled for diagnostic testing for respiratory disorders. The patient who needs post-procedural care that includes frequent vital signs is the patient who had capnography, a D-dimer test, ventilation and perfusion scan, or a bronchoscopy. So now there's 5 people that's looking at here saying, wait a minute, is she crazy? This is an NCLEX question. What is she doing? I'm doing what I love to do. This is it. Okay, so let's look at these questions. I like to use a process of elimination when I am thinking about NCLEX questions. So capnography, you're wondering, you're flipping through your pieces of paper. What did she say it was? Yes, it is the measurement of the amount of carbon dioxide in the bloodstream. Okay. D-dimer test. What did she say the D-dimer was? I remember she said that the D-dimer was testing the activity of thrombin and plasmin. And for the record, I'm not sure if I mentioned this earlier, that is stuff that helps with clotting. Right, exactly, because I said it was very helpful in diagnosing a pulmonary embolus, or DIC, which is disseminated intravascular coagulation. And we'll talk about that too. That's we call it death is coming in in our nursing world. But anyway, all right. So then let's move on to ventilation and perfusion scan. Remember, I went on to say that this one was the radioactive iodine treatment, that we're going to see the blood flow through the pulmonary system. And then the bronchoscopy was the scope or the camera that goes down, and we look around and we can say, hey, everything look good, or wait a minute, let's biopsy that and see what that is. So the question is, I like to go over the multiple choice, go back up to the question, and figure out what is the question. The patient who needs post-procedural care. That includes frequent vital signs. So which one of these patients need to be monitored more, basically? Is it the patient that we're going to do capnography on? Capnography, guys, is just like doing a pulse oximeter. Yep, you're right. No. D-dimer is the phlebotomist comes in and draw blood. No. So we already have 2 of those knocked out. Now we have ventilation and perfusion. Okay, you're right. Yeah, you got to go into a pulmonary. Yep, we're going to a vein, shoot and die. I like that in you. You're thinking, I like that. Yep, you had to check to see if they was, okay, gotcha. Got to consent. So the last 2 you need a consent to do. So I think that alone would lead us to leaving those 2 in. Okay, so Whoever said the bronchoscopy, I like the bronchoscopy pretty good too, because the bronchoscopy is the one that I said, yes, you are right. The patient could actually, the lung could be perforated and the patient could end up with a pneumothorax. So if you said bronchoscopy, you were absolutely right. You're the best. Let's do it. Okay. Next question. Immediately after the physician intubates a patient who is in respiratory arrest, the nurse notes that there are no breath sounds in the left lung fields, but breath sounds are heard. Yes, that's somebody working too fast for you. On the right side, the likely explanation is that A, the tube is in the esophagus. B, the tube punctured the left lung. C, was inserted too far. Or D, is malfunctioning. Now this one right here is going to require you to do a little bit of thinking, because all of that stuff could be true. Yeah, nursing school is the one place where all the answers is right, and you got to pick the bestest. Okay. So, number one, the tube is in the esophagus. If this tube was in the esophagus, would we have the no breath sounds and then the breath sounds on one side? You're absolutely right. No, we wouldn't. We would more so have the distended abdomen or the patient vomiting or something like that, because the esophagus leads to the belly. The tube punctured the left lung. There are no breath sounds on the left side, but there are breath sounds on the right side. So, not so much, but I don't want to take B out, because there is a possibility that that would be the case, that we would have no, if we puncture the left lung. I like this question. I might even put it on one of my little tests that I'm making. Okay, and then C, was inserted too far. Not really sure what that was, not a whole bunch of information. I'm going to hold it for a second. The tube is not malfunctioning. So I'm throwing that one out. So I got rid of A and I got rid of D, and I'm left with the tube has punctured the left lung or was inserted too far. Now here's my question. Why is it breath sounds on the right side? Yeah, because that's where that damn tube is. You're right. So remember I told you that the main stem on the right side is shorter, wider, and straighter. So for some strange reason, foreign objects get down there. We like to intubate over there. If you pull it out a little bit, it'll be in the main, so the lung sounds are heard on the both sides. You guys are great. Really paid attention. I really appreciate it. Last question, guys. When the nurse places the diaphragm of the stethoscope over one of the main bronchi, the expected normal breath sound heard is, when the nurse places the diaphragm of the stethoscope over one of the main bronchi, the expected normal breath sounds. So, as we talked about this earlier today, we talked about where we would hear these lung sounds at. And you guys might have got so caught up in the fact that I was trying to make lung sounds over here, you might not have remembered. But it was on the slide of the chest and all the different places to auscultate. And bronchial sounds are heard over the trachea. Bronchiovesicular sounds are heard over the main stem bronchi. And vesicular sounds are heard over the lung tissue all the way down to the sixth intercostal space. So yes, bronchiovesicular sounds are heard over the main bronchi. Very, very good, guys. Very, very good. I thought it was the last question, but for some strange reason, I have another one. The nurse is observing a nursing student who is suctioning a patient for excessive secretions. The nurse would intervene if the student, 1, pre-oxygenate the patient with 100% of oxygen for 2 minutes. I don't know about 2 minutes, but I mean, pre-oxygenating the patient is not a bad thing. Apply suction when inserting the catheter. I don't know about all that. Set the wall suction at 80. It's supposed to be 80 to 100. I'm kind of cool with that. Monitor the patient frequently for tachycardia or bradycardia. That's the bomb right there. That's assessment. We do that all the time. So I want to know how the patient is tolerating being suctioned. So I like D. I know that the suction on the wall, that's wall suction, guys, should be between 80 to 100. So I'm cool with that. I know that I should pre-oxygenate my patient. I don't see why we need 2 minutes. But I know that I only apply suction when I'm coming out, not when I'm going in. So I would intervene immediately if I see a nursing student applying suction when they're when they're going in. And that's absolutely right. One of the things I want to say to you guys in my and while we're doing this, and I am going to do a little summary, is that I really do appreciate you guys giving me the opportunity to share some of this wonderfulness with you. But what I want to say is make sure that you continue to study. You need to be doing NCLEX questions about respiratory. And you need to make sure that you have a clear understanding of respiratory anatomy and physiology and how the respiratory system works, because we're going to be coming right back with upper respiratory issues. And so I want to do a small little review on what we're doing here. Upper respiratory issues, the tract consists of your nose, your sinuses, your pharynx, and epiglottis. Epiglottis closes so that nothing goes down the trachea that's not supposed to be there. And your lower is going to be your trachea, your lungs, your bronchi. We know that the alveolar is actually where the gas exchange happens, and we need surfactant. So that happens, it decreases the surface tension. We know there's a lot of age-related changes that happen, and some of those age-related changes is that the ciliary movement in the respiratory tract doesn't work, and that's the little hairs that prevent bacteria to come back and forth and keep things from going where it's supposed to go. The lungs get stiff, the muscles don't move the way they're supposed to. You get a hump in your back, so you don't have full lung expansion. So as you get older, you don't have that strong cough that you should have. You just don't respond to illness like you used to. The main issue is for gas exchange. Our respiratory issue is to take in oxygen and to breathe off carbon dioxide, okay, and to get rid of those waste products. So in order for our respiratory system to do its job, we need the lungs to take in the oxygen, we need the heart to actually deliver everything, and we need our red blood cells, hemoglobin, to take things where they need to be. I wanted to talk to you, I talked about what actually regulates everything. And what regulates everything, remember I said, was a spinal cord phrenic nerve, and that the respiratory center is triggered by increases of CO2 levels. So that triggering causes the respiratory center to breathe faster, to blow off CO2 levels, an excessive amount of CO2. So CO2 levels are supposed to be 35 to 45. When they are higher, the respiratory center breathes faster. I told you there was a small population, the COPDers, who actually respond opposite. Their body responds to low oxygenation levels, and that's what causes them to breathe. And if we take that away by giving them too much oxygen, they have nothing to stimulate them to breathe. I told you when respiratory problems happen, it's either because there's not enough supply, that it doesn't get absorbed or perfused, or it is not transported the way it's supposed to be. We talked about different risk factors for people that's going to be at risk for having respiratory issues. We talked about the assessment. As nurses, we constantly assess. We ask the right questions. We get a family history. We talk about cigarettes. We do some education, drug use, allergies. Did you travel outside? How do you eat? What is that cough? How many pillows do you need to sit up and breathe? And I don't remember saying this, but orthopnea. Orthopnea is the inability to be able to lay flat and breathe. And so we all have an auntie or uncle who needs 4 pillows to breathe, or sits up in the reclining chair to breathe. That's orthopnea. Okay, so we asking all of those questions. We are asking all of those questions so that we can get a good assessment. I told you when you were doing your physical assessment, you should do it systematically, the same way every time, with your patient sitting upright, starting posteriorly, going through your lobes, I'm not going to tell you in the real world you should be assessing 26 sites, but NCLEX wants you to test 26 sites. They want you to start posteriorly, they want you to go laterally, and then they want you to go interiorly. They want the patient to breathe out of their mouth so you can hear it, and they want a full respiratory cycle, okay? We talked about diagnostic tests and procedures, and I won't go over all of them again, but one thing I want you to know is we do not send sputum cultures down if the patient has already started an antibiotic. So if the order comes in, you need X, Y, and Z, you want to make sure you get your culture before you start your antibiotic. If your patient has had anything that would put them at risk for that lung being punctured, a thoracentesis, a bronchoscopy, or any of that, you want to monitor for those complications, and you need to know how they look in a patient, not that it is a complication, okay? So when you are sending your patient down for anything that has a angiography, you need to make sure that you know your patient is not allergic to shellfish or iodine or any kind of seafood. That's what we mean by shellfish, okay? Anytime you're going to stick something in something, you need a consent. We need to educate our patient. Oxygen is a medication. It is something called oxygen toxicity. It is flammable. Finding the best apparatus to give the oxygen is a good thing. You want to try least invasive first. If your patient can take a nasal cannula, go ahead and put them on a nasal cannula. It allows them to move around and do things. If your patient needs a precise 35% of O2, you want to get the pink one on the Venturi mask. Think about that. You will not see the partial non-rebreather in clinical practice that much, but it does exist, and that's why I put it out there. Okay, your non-rebreather is ballsy. Your mechanical ventilator is balls to the wall. Okay, there are many ways to maintain an airway. One of the ways are going to be your endotracheal tube, your nasopharyngeal, your artificial airway, or your tracheostomy. Remember, a tracheotomy is the actual incision. The tracheostomy is the actual stoma. Remember, there are several different trachs out there. The obturator is something that needs to be at the bedside. It helps to put the trach in place. And if it comes out, Lord help it doesn't, you're going to put that inside of there and put it back in. Yeah, you're going to wash it off, I guess. Okay? Don't forget about that. Suctioning, don't forget it. You're going to get your equipment. You're going to come into the room. You're going to identify yourself, explain the procedure, wash your hands, set everything up, pre-oxygenate your patient. You're going to moisten the catheter. You're going to stick it in until you meet resistance, pull back a little bit. You're only going to apply suction as you are coming out intermittently, thumb off, thumb on, thumb off, kind of twisting it a little bit. You're not going to stay longer than 10 seconds down there. The wall suction is 80 to 100. Always monitor your patient to make sure they're tolerating the procedure well. Ventilator alarms, if I wanted to tell you to remember anything, that's what I would tell you. The ventilator alarms, if it is a high level alarm, and it will say beep, 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 and you will look at the ventilator and it'll say high alarm, high pressure. That patient either coughed or sneezed. They're trying to breathe against the vent. They're bucking. That's what we call bucking the vent, meaning that they are fighting the vent. We might need to give them anti-anxiety or a benzodiazepine. We may need to suction them because something is causing extra pressure and there may be a clot or occlusion. Low pressure alarm, I'm going to check from the ventilator to my patient, from the patient to the ventilator, looking for loose tubing, leaks, and leaks. If these alarms will not stop making noise after I didn't troubleshoot as much as I could, I am going to take my patient off the ventilator and manually bag my patient until respiratory comes. Or your procedure may be to call a rapid response. As a nurse, my nursing goals is to always promote oxygenation, prevent infection, prevent further lung damage, and promote rehabilitation. I really appreciate spending this time with you guys. I can't wait to put up upper respiratory infections, lower respiratory infections. Really, I'm only doing this because I'm trying to hurry up and get to cardiac. Hi. Yep, I'm having a great time. All right, if you have any questions, once again, you can contact me at D, and then my first name, SHEMELLE @yahoo.com, or hit me up on the page. I hope you guys enjoyed it. Talk to you later. I like how I keep thinking that the screen is a touch screen.